Thank you very much for this introduction. We were almost overwhelmed a few minutes ago for this nice presentation of the absolute substantial breakthroughs in the treatment of diabetes, particularly diabetes nephropathy. I will do something very much more simple. I will confine my presentation to metformin, and you will see for two reasons. For the first time in the history of that drug, which is a 60 years old drug, is almost in retirement, this drug can now be prescribed to renal failure patients. Until 1970, 1918, it was absolutely not allowed to progress and to prescribe it. I will show you the evidence that this is possible. So metformin still is the first line drug of choice for the treatment of type 2 diabetes. So it still is, and the pharma industry do not like metformin because metformin is so cheap. You can have a full treatment of metformin for €1 or €2 per week, which is dramatically different from all the drugs we have now on the market coming. And furthermore, it seems to be still very efficient. But the problem is that industry is not interested to invest anything in metformin anymore. So we did it, and I will tell you how we did it. It's one of the few anti-diabetic drugs organized and considered by the WHO as essential medicines. And a very important issue is this. This drug is eliminated only by the kidney, by glomerular filtration and tubular secretion, at the speed of 550 ml per minute. This is exactly the same as the plasma flow. So the disappearance of metformin out of the body, when your kidneys are normal, is very, very fast. On the other hand, and that's the major complication which was always present with metformin, when your kidney is failing, the accumulation of metformin is going very, very fast. So that's very clear. And as shown here, in one of these slides, is this a beautiful slide of a plant which in the 16th century was already known to contain a drug against diabetes. And the people considered diabetes when you had to go to the toilet every hour, or when polyuria was a classical symptom at that time. And when they took this plant, they could demonstrate that stops this polyuria because the diabetes was better treated. So it's not a new drug. And it's the same plant which still is used to produce metformin. So we know that this metformin has several pharmacological activities. I will not go into detail of that, but anyway, this is a very efficient drug which decreases the glycemia, and it is the only drug in the whole armamentarium where you cannot develop hypoglycemia. You cannot kill yourself with metformin through hypoglycemia, even if you take grams of metformin in a few minutes. The second thing is, of course, the clearance, and here you see the beautiful synthesis of this, all the studies, pharmacokinetics studies, and this is the renal function. And if your renal function goes down, you see that the metformin clearing is going down, and this curve traverses the 0 point, meaning that the kidney is the only organ which can eliminate metformin. Because if the liver should do that or something else, this line should cross this y-axis, because this is the contribution of another organ, but it's not the case here in the case of metformin. Metformin can induce or can help in the development of lactic acidosis. And it is well known that this occurs in cases of anaerobic conditions. It's difficult when you have a normal renal function and you have a normal metabolism. When you take metformin, you will never develop lactic acidosis. It is a configuration of a status of infection, a status of cardiovascular insult, a status of hypoxia, etc., which comes together, and with metformin can induce lactic acidosis, which is a serious complication, as we all know. I will spend a few minutes on that. This is lactic acidosis. Lactic acidosis is a diagnosis, a clinical diagnosis, but also a biochemical one. Lactate higher than 5 millimoles, decrease of pH, and an anion gap, and a lower concentration of bicarbonate. So what can we tell about lactic acidosis? This is an overview of the different important studies, and there are many, but I can only show some, that the case of lactic acidosis is extremely exceptional. In all the clinical trials reviewed in a Cochrane review from 2010, there was no case of lactic acidosis. This is a study of United Kingdom that the incidence of lactic acidosis was perfectly comparable in patients receiving no metformin or metformin. So there was no higher incidence of lactic acidosis, and etc., etc. There is only one paper last 3-4 years ago, where people from Taiwan, the nephrologists and endocrinologists, were using metformin all over the renal function, up to CKD5. And this is something which is still a contraindication. We will see later on in my talk. But they have done that, and they have studied the CKD5 patients with diabetes receiving metformin, and there the mortality was higher because 35% had a higher mortality risk compared to those without metformin. This was a retrospective study. We wrote a letter to the Lancet with some of our comments. There was no clear definition of what kind of death, what was the cause of death, the doses of metformin, and there was no any metformin level determined in these patients. The major lesson of that paper is we should not use metformin in patients with CKD5 just before the dialysis, because the accumulation of metformin is so fast because there's no more renal function. So to summarize that on lactic acidosis, what can we tell is that the risk of lactic acidosis is essentially nil in the context of clinical trials. Okay, this can be biased, of course. It can also show that lactic acidosis is not necessary, that metformin is not necessarily responsible for that. And finally, a conservative synthesis is, as long as the kidney function is stable and the patient is observed closely, metformin is unlikely to measurably increase the risk of lactic acidosis. Do not use metformin in CKD5. And if there is a case of lactic acidosis, or if you're confronted with someone who is under metformin treatment and lactic acidosis, it's sufficient to do a dialysis of a few hours, and I give you 2 case reports here, with a dramatic anion gap and a very low bicarbonate and a very high lactic acid. Well, in a few hours of time, these patients, while completely rid of metformin, have a restoration of the bicarbonate, so the nephrologists can do a very good job. If whatever case of lactic acidosis is considered to be present, it's sufficient to do a dialysis in that particular patient. So these are the guidelines over the years of all different societies, American, European, etc., all saying that there is an absolute contraindication when there is creatinine lower than 60, some lower than 30, very heterogeneous, so nobody had very clear messages. The only clear message was, do not use metformin in renal failure. So in April 2016 and October 16, the EMEA, and April 16, the FDA, they started saying, under the pressure of many scientists, patient organizations, etc., let us use metformin in CKD patients and let adapt the dose. And both organizations decided to do that. But the problem was they have not shown what is the dose adaptation. There were no studies available on how many percentage of decrease of dose we have to apply in the different CKD conditions. So that was something very strange. But anyway, so we decided in the French group, together with the French group, to do 3 studies. And these are presented here. We first started with a dose finding study, just to find an acceptable dose in patients with CKD 1 to 5, 78 patients, diabetic patients with different doses and different GFRs. So we give them 500 milligrams a day, once a day, during 1 week, wash out. Then later on, after the washout, the same patient, 500 milligrams 2 times a day, 1,000 milligrams, and then again the washout, and then the last study, 2,000 milligrams a day. And we followed them during a week, and we determined in these patients the trough level. And the trough level gives you an idea of the steady state concentration at which the metformin or any other drug is behaving in your patient. So these points are all trough levels in the serum. This is CKD 1, 2, 3A, 3B, 4, and 5. And you can see that the trough level is increasing, which is totally logical because the renal failure is developing. And if we look to the 2 times 1,000 milligrams, this is not good because you see that the points of the trough levels are below 2 milligrams per liter of metformin. And suddenly they go up, and then already at CKD 3A or more than 5, and more than 3, 4, 5 is already more than 2.5, sorry, is a reasonably not a good concentration, is accumulating, showing this accumulation, and all the patients with CKD 4, 5 had very high levels of trough levels, so this dose could not be used in these patients. Situation is more better when you use 2,500 milligrams, as shown here. Already until CKD 3B, not a single patient had a higher concentration than 2.5 milligrams of metformin per liter. Only at 2 times 500, 4 and 5 already had some patients with accumulation. And here you see the 500 milligrams, and you can see that until CKD 4, not the same except one, there are no patients having a higher concentration than 2.5 trough level, meaning that these doses can apply in renal failure. So we think that you can still use 500 milligrams in CKD 4. We propose to use 1,000 milligrams in CKD 3B and to give 1,500 milligrams in CKD 3A. And I will show you now if this is true. So this is a second study. We give during 4 months 500 milligrams and 1,000 milligrams, 1,500 in CKD 3A, 1,000 milligrams in 3B, and 500 milligrams in CKD 4. So this results in the following, that all the patients CKD 3A, 3B, and 4 at that adapted dose had absolutely no increase over 4 months. The mean level of metformin was exactly stable over this period of time for CKD 3A, for CKD 3B, and for CKD 4. So meaning that this dose schedule is a correct dose to apply in your patients, as long, of course, that this patient is in equilibrium and is not doing, has not submitted to an aggression of acceleration of renal function decrease. But if it's stable, you can use this kind of dose in these different CKDs. And finally, we looked to the lactate levels, and we had 3 patients developing a lactic acidosis. This one developed a lactic acidosis without any major sign. This was a patient who developed cardiovascular insult, and this also one. And when we stopped the lactic acid, the metformin, this normalized immediately within 1 week after arresting the drug. So this is out of 75 patients and the problems we had with lactic acidosis. So finally, we did a pharmacokinetics study in these three classes of patients, and we used several, the classical parameters, area under the curve, Tmax, T1/2 lifetime, Cmax, and CASS. I like this one because this is average concentration at steady state. And you can see that all the parameters are absolutely non-significant, meaning that all the parameters remain stable and not changed all over the 3 different degrees of renal failure, clearly proving that this dose and this dose adapted of the renal function is the correct way to do it. And finally, this was the hemoglobin A and C, and this remains perfectly stable, meaning that pharmacologically, the low dose of 500 milligrams was still able, because this is 1, 2, 3, 4 months, CKD A, B, and 4, and the hemoglobin A and C remain stable in all these conditions, meaning that the activity of metformin in regulating the metabolism of glycogen is okay. I will end in the last 4 minutes. I will end to show you, is metformin a renoprotector? And this is very new. This is recent information out of the literature and our own experience in our lab. This is a beautiful study of an American group. They used remnant kidney. And this is a classical model in the rat. The rat has 3 arteries on the left and 3 arteries on the right. And you ligate 2 of them on one side, and you take out the kidney on the other side. So remain with 1/6 of the blood flow in one small kidney, the remnant kidney. Classical, Brenner has done all his studies on hyperfiltration of that. So you can use that model if you have a beautiful model of a chronic renal failure in the rat. So here you see the GFR on the control value, and you see the GFR after 7 days already, a drop in the GFR, dramatically drop in the GFR in the rats in the remnant kidney. And if the rats receive metformin, there's absolutely no difference in the GFR compared to the control rats. Which I think I want to show you, and is more important for me, is the following. This part of the slide. This is the biopsies of the rats at the end of, at 7 days, at 30 days, sorry, 30 days. This is the rat's remnant kidney without metformin. You see already the collapse of the glomerulus, and you see a profuse fibrosis in the interstitium, which is very classical as chronic renal failure is advanced. You have already this beautiful fibrosis. Metformin is exactly at the same age, 30 days, normal glomerulus, no hypertension, no interstitium increase, and absolutely no fibrosis. So metformin is protecting the kidney by not forming apparently fibrosis. Let me see if there are other arguments in other models, and I give you 3 other arguments. This is another paper, another group, but using the obstructive classical model of renal failure. And you see again that the fibronectin, this is the control, this is the ligated kidney with profound expression of the fibronectin, and this is the metformin treated. So, and finally, we did a study using the adenine, which is a model of nephrocalcinosis, with metformin, no change in, almost no change in the GFR, an extremely increase of the serum creatinine showing the renal failure. No vascular classifications in the metformin group, and biochemically and molecular biology, different markers of fibrosis were downregulated. So we have this dramatic proof that in 3 different models, and I like very much this publication.
Dear doctor,
you have 2 minutes or more you want?
Sorry? 2 minutes.
2 minutes, all right, yeah.
Of this transplantation of cyclosporin, is a paper from China. Can you
Yeah, just to give him a second. Yeah.
Can you show me the slide? Otherwise,
Yeah,
I cannot
they will
talk.
show you.
I need some more time. Thank you. So, this is the paper of metformin. Okay, I can tell them by heart. They used the cyclosporin model, and they have given metformin to the rats. And they have shown absolutely very prominent protection, again, non-fibrotic effect on the development of this disease in the rats. And they found also a very particular pathway. I cannot discuss that for the moment. But I come back to my slides of 2 days ago, where I explained to you that in cyclosporin, and all the patients receiving cyclosporin, we have observed these lysosomal lesions, which are going along with the development of a chronic renal failure in transplantation and in patients with the famous pesticides-induced chronic renal failure in many countries of the world. So we think, and we see in those biopsies of those patients, this is the patients with pesticide-induced chronic renal failure, the atrophy of the proximal tubular cells, but also the massive fibrosis and the atrophy of the proximal tubular cells. So it could be that this metformin could be a wonderful therapeutic approach in this disease, provided you come on the scene relatively fast. Otherwise, the fibrosis, when the fibrosis is there, you cannot solubilize the fibrosis. You have to come in with the drug at a very early phase, because otherwise fibrosis will be there and the renal function will go. And to show you that probably this is true, I've shown you this meta-analysis, where this showing the meta-analysis to see what is the mortality of all causes of mortality in CKD receiving treatment regimens. And this is metformin. And all of them show clearly that there is a protection in the mortality of the patients with CKD and diabetes compared to other conditions with other drugs. One point is interesting, extra, the same publication found that CKD 45 to 60 was protected to a certain extent, but once, in the same study, the group of 30 to 45 was not protected anymore. And this fits perfectly with the concept.
Dear doctor, your time is up.
If your kidney already is fibrotic, you cannot help. It's too late. Your protection is not there. And once the fibrosis is there, and that is a most beautiful example of
Thank you very much, Professor. Do you want any more time?
No, I will finish, I will conclude.
You want to conclude, all right? Can we give you another 2 minutes just to conclude?
Well, I can, if you give me two more minutes, I can conclude. So what we have done for the moment is we have started a randomized clinical trial, which will do the renoprotective effect on patients with CKD, non-diabetics, to be very clear. And what was my motivation? My major motivation was what I have explained you on the fibrosis, but also this simple experiment and simple study of transplantation, living donors and deceased donors. This is a retrospective study of an American group, and they looked to 45,000 patients, and 12,000 of them had received metformin post-transplantation. And here you see the living donor and the deceased donor. And this is the patients with metformin and without metformin on living donor, percent graft survival and patient survival. And you can see that in the deceased donor transplantation, also the living donor, there is an improvement of more than 50% in graft survival in patients receiving metformin post-transplantation, which is a dramatic number. So we decided to do metformin renoprotective in non-diabetic patients with progressive chronic renal disease, 2, 3A and 3B, is a multi-center, practice-oriented, and double-blind, placebo-controlled and randomized trial, which will, I will jump that, I will just go to the conclusions. So in the conclusion, I want to say that metformin was and still is an important drug in the treatment of diabetes, of course. We found that in CKD 3A, 3B, and 4, when adapting the doses 1,500 3A, 1,000 3B, and 500 and 4, you can use CKD, you can use this drug in patients with chronic renal failure if, of course, the patient has a stable renal function, and if there is any risk, like congestive heart failure, sepsis, acute renal failure, etc., we should stop. This is a clinical interpretation. We should stop for a certain time period the metformin and start eventually later on when the situation is under control. I think CKD5 remains.
Dear doctor, your time is up.
Finally, I think that renoprotection of metformin has been proven experimentally, and we are trying to prove it in human beings in a prospective way. Thank you.